So with breastfeeding at the Royal Hospital for Women, just a reminder that as part of the LHD, we are an accredited baby-friendly health initiative. So also as part of the GP shared care, we look for your support to help us in the antenatal period, essentially. So lots of the information that we give these women, we need, if we don't get to see them before, we need you to pass this information on. So I guess my objectives at the end of this is to give you a little bit of management on breastfeeding issues, but also how important it is in establishing and maintaining breastfeeding as a biological norm for a long period. We have to capture these women and give them informed information antenatally, because their decision to breastfeed doesn't generally occur before they become pregnant, but most of it will occur when they're pregnant, basically. Yeah, so far right? So I'm going to try and rush through a lot of this stuff. Just stop me if you think it's like too much. Okay, so has everyone seen this about supporting breastfeeding? This is a national strategy for optimal infant growth. So we've got an implementation guideline, and New South Wales Health has just put out their strategy, basically. So that's breastfeeding, protection, promotion and support. That was for 2018 in line, and just a reminder that the Royal Hospital for Women is accredited every 3 years. We've been BFHI accredited since 1999, and the last, you're quite safe now at the moment because the last accreditation occurred in April, so you've got another 3 years, so to speak. So we actually work in line with World Health Organization and UNICEF for a global strategy to, well, mostly what BFHI is about safe infant feeding, it's about maternal welfare and optimal infant growth, basically. So, however, if they choose to formula feed after information, then the Royal also and I have developed a package for these women who choose to formula feed. So the information is going to be evidence-based. So I would not be promoting any brands because that would contravene the WHO code. I would be giving them information on various things, all sorts of formula that's on the market in specialised formula. And then I'm actually giving them the evidence behind anything that they buy at the supermarket, things like that. Yep. So if you need to access that, I've made that into, it's like we give it to them as a booklet. So it's patient information for the parents that choose to formula feed, and it's on our P drive, but you can still access that. What I've done is occasionally we've actually made it into little brochures and we hand it out, basically. So if we know they want to do this antenatally, they gets it antenatally, otherwise the postnatal midwives will hand them out. So the importance of breastfeeding, as I just said, it's about World Health Organization and UNICEF, it's their recommendation, and it's about exclusive breastfeeding for the first 6 months. And then they start solids, and then they can continue to breastfeed in spite of what people think for 2 years and beyond. National Health and Medical Research actually just says continue breastfeeding for 12 months. But it can be longer if the woman and the child chooses to do that. Now, we've updated, the World Health Organization has updated a revised step. So the framework on how maternity hospitals work for the accreditation and to protect, promote and support breastfeeding is called the 10 steps. That is the framework, and essentially if you look at it, it will show you that it's just, it flows on. It's about caring antenatally, during labour, postnatally and community. So for a lot of cases, ongoing assistance and community assistance is very important. It's not just about what happens in the hospital. So these are the World Health Organization revised 10 steps. They're probably a little bit better and less didactic than what we had to work with. And you'll find now, because this came out in 2018, in line with our BFHI, I actually started putting up these posters and just putting it together. So when it comes out on, if you look up on the website, it won't look like that. It's because I've just put it together like that, and then somebody helped me put these big posters up around the Royal. So it's an easier concept for, and it's not just for the staff, it's for the women and their partners and their families, and this is about this. So obviously we need policies. we need the staff to be competent, so I do the education. The antenatal care of these women, just for information and informed choice, is seriously important. So what I'm getting at is the other thing that is required is that these women are actually informed prior to 28 weeks gestation. So if they're sharing GP shared care and they need this information before. I'm not suggesting that you, sorry, that those chairs never work. You notice? They're projectiles. Don't panic. So, yeah. Was there any food on there? No? Good. Okay. Yep. So it's really, really important. So what we've done is on the antenatal card, I've put little flyers on it. It gives them a brief outline of what it is we're doing and the 10 steps basically. Then it also gives them very quick contact details on who they can contact if they've got a question. I think what I'm trying to ask you is to flag it, that it's on there, and even date and sign it, that you actually said, oh, have you looked at this? I'm not suggesting that you sit there and read through it or tell them about it, but it's, have you read it? And this is the person you can contact if you've got any questions, because you don't have time and you've got a lot of stuff that you have to do with them. So I'm happy, my phone number's down there. This is a public system, so it just says lactation services. That would be me. So those are the 10 steps. Antenatal care. Care right after birth just means that it's ongoing. It's skin to skin. Skin to skin is seriously important. Sometimes maybe underrated. And this is the mother's right and the baby's right, and it's got high protection. This is all evidence-based, so it's about the neural protection, their adaptation. So this is across the board, whether the woman chooses to breastfeed or bottle feed, skin to skin is the right because it has immense properties of protection. So especially if the woman decides not to breastfeed, then skin to skin is required for at least an hour, because this is how she's going to pass on immunological factors through her skin flora. So gone are the days when the mothers were kept away from the babies and it was all the, you know, the nurses and the midwives and the doctors and everybody else had to gown and glove and look through screens. The mother's flora is the most important one, because this is how she's going to continue the activation of the baby's gut flora. And I'm not, you know, I'm sure everyone's already heard about microbiome, microbiota. That's been on forever. And I'll talk a little bit quickly about, you know, everyone's going, give the mother prebiotics, give the baby prebiotics, but essentially the most important passing factor of immunity would be the mother's breast milk, and the most important thing, I'm a great fan of colostrum. So as far as I'm concerned, if the woman breastfeeds for just 2 weeks, as far as I'm concerned, she's successfully breastfed, because she transferred colostrum, which is the only component that contains prebiotics that will grow the probiotic in the baby's gut. So vertically, she already gave this to the baby. She's already protected the baby. Ongoing, she will do this with her colostrum. And then the colostrum becomes vital if she happens to deliver a preterm baby. And then I'm going to tell you too, that the other thing that you need to remember about colostrum, and especially in preterm deliveries, I'm not going according to the slides, have you noticed? Yep, sorry. Is that it's slower, it's much needed for the preterm baby. The baby is, gut maturation's not there, so therefore it doesn't require large amounts. And so the colostral phase for a woman who delivers a preterm baby is going to be longer. So we don't need to upset her going, oh, is that all you're expressing? Because that's what happens, and then they get upset, and that can lead to depression. They're not going to get a lot, because the baby doesn't require a lot. The gut won't cope with it, and neither with their kidneys. So we know that, and we know that the first expression is really important to get it going, and then it's just a matter of the body of the woman is so clever that it knows this is how much the baby needs, and this is what the baby needs. And really, colostrum transitions, your mature milk and evidence doesn't actually occur before 20 days. Colostral phase can go up to 20 days, basically. It's the volume that does increase because of the lactose, but that's how it is, yeah? So that's why you'll find when the women express, if they're expressing and they go, oh, I haven't got enough milk, For the first couple of weeks when they express, it always appears yellowy and thick first, and then it gets watery and thin as the volume increases, and then it gets all concentrated again towards as the breast is draining. So I never say to the women, empty the breast, because as far as I'm concerned, while they're breastfeeding, again, this is a miracle, they never empty. That's not how their body works. They're continually functioning to support and protect their child, so they're never empty. It's just that the milk ducts might have drained a bit more, that's all. So the milk then becomes more concentrated at the end with a higher content of fat. I don't talk about fore milk and hind milk because it's not segmented. It's transitional during the feed, and it changes during the feed. So every time this woman has a letdown that's initiated, it collects more fat and passes that through to the baby. So when I explain to her about how she knows she's drained a breast, it would be about look, see, what is the baby doing, and if she needs to take the baby off, hand express, and she'll see the colour and the flow. And that will indicate to her whether she goes to the second breast, depending on what the baby needs and whether the breast is drained. So that kind of also ties into, you know, your common problems like mastitis, blocked ducts and things like that, and misdiagnosing mastitis when the breasts are engorged, which is not fun either, but it's not mastitis, and then commencing antibiotics before you're really required to do any of that. So far, all right? Okay, so we're just going to move on with that. Again, I said it's national strategy. We adhere to the International Code of the Marketing of Breast Milk Substitutes, and the initiative actually started in 1990 and came to Australia in 93. The BFHI actually went to the Australian College of Midwives. It was owned by UNICEF, and the framework for us is the 10 steps, but there's also a 7-point plan in community. The Australian College of Midwives also has a baby-friendly health manifesto. That's you'll read that in, and that's just a declaration basically about what baby-friendly health initiative, because it used to be a hospital initiative and then it became a health because we were including community in this. So everywhere you go, pretty much we are reflecting the 10 steps, and all our policies are related to New South Wales health policies, but we write our own local operating procedures. What I've done in there is tried to give you, these are all, I mean, I've got a policy for just about everything we try, and the point is that if you want some information, to go into the RHW website and pull those, what we call local operating procedures, because we write it differently. They're not clinical business rules, they're educational notes, they're clinical practice, and they're referenced, basically. Very, they're reviewed every 3 years, and the most current referencing is put in there. So it actually tells you how to manage certain things if you actually look at the policies. So it's not just something from New South Wales Health. There's 2 on mastitis. One is an LHD one, and then one is ours, a local operating procedure. And the reason we had to do that was because the mastitis policy for LHD did not cover issues of readmitting mother and baby when they're unwell. So we've had, what can I say, a few issues with baby being unwell, and so we don't have border babies. When the mother's unwell and we admit them to RHW, the baby comes with the mother's permission, and the baby is admitted and reviewed by a ped. And then we actually do OBS if the mother's septic. These are the patient information leaflets that you can actually access on the website as well. So some are from RHW and the rest are the LHD leaflets, but they also come in multicultural leaflets. They're on our P drive, and I can actually get you to access the handouts. And these are the handouts that we give the women postpartum, generally. Not all of them, most of them. So, you know, things like nipple shields and stuff we don't pass on simply unless we're actually they're using it. Then we give them the information on that. So the importance of antenatal motivation, education and support is seriously important, as I said, because 2/3 will decide during their pregnancy. So it's really important as soon as you see and talk to these ladies that we actually ask the questions, not generally just about breastfeeding, but to do a breast assessment. Because in the last few years, there's been, a few more incidences of women halfway through their pregnancy being diagnosed with breast cancer. And I've actually been called a number of occasions in the last 2 years to help women suppress lactation abruptly because they needed chemo straight away as soon as the baby was born. We've also had incidences of women who've already come in, so we'll go into breast surgery, who've had mastectomy. So it's not an invasion of privacy. I think that we know how to ask these women about any breast development and not to be too, I guess, blasé about, you know, oh, you've got a few lumps, it's all right, it's just your breast developing, to actually examine, ask their permission and to do it. So that's what I do if I see them antenatally, if they get referred for anything, and I ask their permission and just have a look and just see if there's any changes that they thought seemed a little bit strange outside the normal changes. The other thing that we will put in here now is has everyone seen this one? It's called the First 2,000 Days Framework. So it's about conception to age 5, and we're in the process with New South Wales Health to go through drafting implementations on the 2,000 days. So the evidence is from conception to age 5. It was initially the first 1,000 days, but the evidence is showing that attachment relationships, brain development occurs from conception and especially in the first 3 years. So the cortex of the child and adaptation to resilience and emotional intelligence occurs in the first 3 years. So it's seriously important about whether it related to breastfeeding, mental health of the mother and the relationship of her and her child. So that goes antenatally, and also with the child's childhood experience. Now this is also, you can access, so I've given on part of the slides is all the access where you can, the websites basically. Again, like Professor Lowe said, because I had to put this in rather quickly, I added a few more. So if you want, I've also got the website or where you can get this publication of the First 2,000 Days Framework. The service updates that the Royal has for LHD here are the antenatal clinics. So I run an antenatal clinic on the first Wednesday of every month. I mean, I know that's not sufficient, but we don't have any more clinic space and stuff. And the other thing is, if I miss anyone or the clinic is overbooked, then I suggest to the midwives and to the GPs that handout that's on the antenatal card, that's my phone number. They can ring me and I'll just juggle the appointments in my diary outside clinic hours, aside from, you know, whatever. The most important thing I need to see is breast surgery. There seems to be an increase, especially in the eastern sector here, a lot of breast surgery. So the other thing is, if they didn't notice any increase in breast size by the 3rd trimester, no. If you've noticed or identified some kind of breast hyperplasia, if the previous traumatic breastfeeding history, nipple inversion, diabetes. So diabetes also gets referred to me. So if the diabetic educator didn't catch them, I catch them, essentially. But that's mostly about antenatal expressing, and it's mostly because, as you've heard, with whether it be gestational diabetes or diabetes, as such, there are so many variables that it could occur, but it will actually impact on one of the 10 steps, and one of it would be no immediate skin to skin because the baby's compromised or the mother's compromised, basically. So then they get taken straight to newborn care, and then it just goes by the byway. So if the woman misses an opportunity of skin to skin immediately from birth and the first breastfeed, and nobody helps her express to remove the milk, then the projection of her actually building up a supply drops by half within the first 6 hours. So we need to get to this lady rather quickly. Antenatally expressing doesn't necessarily actually increase the supply, it's just more, it's like a second plan. So in case the baby's separated and doesn't get back to the mother immediately, then we've got one feed. She's not panicked, and then we can help her express and get her united with the baby, whether we're taking her to newborn care or the baby's getting better and we can bring the baby back to the postnatal ward. But mostly we'll take her down to newborn care. So far, all right? Any questions? So the referral process is just for you to identify the issues and refer. You can ask the woman to actually contact outpatients here at the Royal, and they'll make the appointment for her. If there's no appointment, they will give her my phone number to give me a call, and I'll try and reorganise my appointments to accommodate her. We also give the women, this is part of the Baby Friendly Initiative, so they have information. There is now a 26-week pack that contains all this information in there, and there's a 31-week pack that we give them. So with breastfeeding information, we talk about and warn them about the importance of why we do 24-hour rooming in, which is, again, ongoing. It's a non-separation of mother and child, the skin-to-skin, breastfeeding the first week handout, all about the community supports, their contact numbers, and we are required to actually advise them why we discourage the use of dummies and teats while they're breastfeeding, but also just for the oral development of the baby's mouth, long term, generally. So the antenatal breastfeeding discussion groups that I run is every Thursday in the mornings from about 10:30 to midday. That just is every day in the physio department. Then we run one on the first Tuesday of every month, but that's in the evenings, and that's to help the couples that want to come as a couple and don't want to leave it to too late. So we capture them earlier if we have them on the evening ones rather than in the middle of the day or the mornings, because often they're still working. So we've got a 31-week pack that we give them as well, and that's, again, all the numbers are in there. So with the antenatal and postnatal breastfeeding support that I provide, it's the antenatal classes, and it's also postnatal classes. So the postnatal classes run Monday, Wednesday and Friday. All these classes are free for these women that deliver at the Royal, and they can come. So we do encourage that, and this information is also on that antenatal card. This is what it looks like. So what we need to happen is that the handout's actually signed, and it's signed before the BFHI accreditors go to these women by 28 weeks and ask them the question. So pretty much if you sort of say, yep, I told them that, but that piece of paper wasn't signed or dated, and the mother says, I don't remember, then it's a fail. We didn't inform them, so they weren't informed. So it talks about everything from antenatal breastfeeding classes to mother-friendly labour practices to what happens after the baby's born, rooming in, little tips on feeding the baby as often as the baby supplies the feeding cues, why we discourage the use of dummies and teats, and supplementing, and then community health numbers, basically, including the Australian Breastfeeding Association. So that's best practice in this case, because again, like when we were talking in the previous topic, the mother or the woman actually needs to feel like she's supported and that she can talk to somebody without actually being judged. And there's no biases. So the Australian Breastfeeding Association works like that, and it's more like a village and a community, and everyone's doing something that will help the woman actually feel a little bit more confident and, well within her own efficacy, because she's worth it, generally. The GP shared care, we also have this handout that we give out for the breastfeeding education and support. So that just provides the GPs with where they can actually go to, numbers that they can contact and referrals. So that's another little thing that goes out in there. Sorry, everybody good? Yeah. That's there, isn't it? It is. It was for BFHI. Yes, they put it in there because Kirsten and I worked on this and we updated it. It was updated in 2017, so those are the numbers and the list and what to do. Do anybody recognise that? No? You should be able to get that. Yeah, sorry. So benefits of breastfeeding, complete nutrition for the first 6 months. All the evidence are there. And yes, the breast milk does change during the feed over months and years to meet the baby's needs. So there is no time the woman breastfeeds where there is no nutrition or immunological developments there. None. Skin to skin during breastfeed, again, then encourages the mother's response, the baby's response, and it's very species specific. The colostrum, the mainstay, the first immunisation. It's evidence to reduce infant mortality and morbidity, but most evidence is again for NEC and sudden infant death in spite of what people think, and the morbidity for decreasing the risk of gut infections, respiratory, urinary and ear infections. So now what we're talking about is not just about the benefits of breastfeeding, but the risk of not. So you can see from that graph that there's a higher risk of respiratory disorders and mortality with not breastfeeding, pretty much. That and gastro infections. The baby benefits, again, it does enhance the baby's own immunity that the mother gave it in the first place. It does reduce atopic diseases, autoimmune diseases. So back to diabetes, the evidence again is dose related. For the woman with diabetes, gestational diabetes, she decreases her risk of developing type 2 diabetes with the longevity of breastfeeding. And then she also reduces the risk of the baby developing or the child developing type 2 diabetes, and that's evidence as well. And it definitely does increase cognitive development. The preterm human milk has higher, obviously, advantages, and that's why colostrum is seriously important. So it's got more concentrations of the amino acids that actually needs extra formulation in formula for preterm babies. Higher concentrations of the essential fatty acids, so the baby can digest this. It's very low renal solute load, and it's very biospecific for the baby, i.e. it sort of does provide gut maturation, which is what actually causes the morbidity in preterm babies. So we want the intestinal maturation to occur. The mother benefits is that, that's why the skin to skin in the breastfeeding, the oxytocin actually does decrease the risk of postpartum hemorrhage. Evidence for breast, ovarian and endometrial cancer with osteoporosis. I know the little myth is that if you're breastfeeding, then your baby's going to suck all the calcium out of the bones, and that's not true. Again, dose related, and I'm sure the women are not thinking about this now, but the evidence is that the longer they breastfeed for, the less likely they are at osteoporosis when they hit menopause. So, and if you ask most women, then they're going to talk about I'm breastfeeding. Well, yes, to protect my baby, but also I hear that it will get me back to my pre-pregnant weight. And as previous discussion, it does delay fertility. Only if you're exclusively breastfeeding. So you've got to be breastfeeding nearly all the time. The economics is that you will have a healthier baby. It's cost effective, it's cheaper, and it's environmentally friendly. The differences in human milk and formula, and I'm just being, a bit facetious, because you're not going to be able to read this, but that's the difference. So this is all the components in breast milk, and then that's what's added in formula. Is that kind of like, yeah, you're not meant to read that? Yeah. So human milk is very specific. I didn't quite de-identify this photograph because my godchild said I could, so she's fine. Yeah, it's 5 minutes, yeah. So human milk, first milk, prolonged in preterm delivery, like I said. It's laxative, rich in immunoglobulins, high in developmental factors, low concentration of lactose. The primary function is immunity, and it's 100% safe, 100%. So we'll go through this rather quickly, but the immune factors that I want to talk about is lactoferrin and lactoalbumin. Now the lactoferrin is about binding and transport of iron, so this is how good the mother's milk is. It's antibacterial, antiviral, it is actually anti-carcinogenic, parasitic, and it's an antioxidant. And this is another research thing. It's called human alpha-lactoalbumin, and this is in the component of colostrum, and it can actively kill tumour cells, and it's the only lactoalbumin that can actually weaken the MRSA cells. Is that new, or am I telling you something you already know? And the name may not be original, but that's what it is. And this is contained in colostrum. Oligosaccharides are sugars, but they're prebiotics. They're very specific. And they will bind and inhibit pathogen binding. It does colonize the baby's microbiome. And, you know, like I said, initial colonization is vertical from the mother, and then it's skin to skin and breastfeeding. If you can't do breastfeeding, it's skin to skin. And this is the continuity of colonizing the baby's microbiome. The growth factors, see what it does to the kid's hair? I mean, pretty good, don't you reckon? That's real. That kid arrived, the hair arrived before the kid. It was like really cute. Yep. He's happily feeding, that's all good. And this is all the growth factors in breast milk. You are not going to find this in formula. Lots of it. Very, very important. So all we're going to say is that it's the standard, gold standard for human infant nutrition. They are bioactive components and they're safe. The composition will change according to the baby's needs and the baby's gestation, and the variability for the infant's health and survival, especially in preterm babies. The composition will be altered and can be altered, not necessarily with expressing, but pasteurization. Different formulas, casein or whey, amino acid, higher protein levels is required to meet so they need to increase the protein to increase the amino acids, which then causes higher weight gain, obesity, and chronic disease. So you can see the difference between human milk and then infant formula, cow's milk and infant formula. Goat's milk is even higher, and then there's, in my information pack for the women who also choose to formula feed, I talk about hydrolyzed, soy-based, goat's milk, amino acids, pre and probiotics, and I think I just gave the bone broth a miss somewhere. Just didn't worry about that one. So the advice is that if you're going to offer advice about formulas, National Health and Medical Research is just to use cow's milk-based infant formula for 12 months. Specialised formulas need a prescription, and that's done by a paediatrician. National Health and Medical Research doesn't actually advocate soy or goat's milk, especially soy in preterm babies. It's contraindicated. And avoiding any particular foods, again, there's no real evidence against doing that and preventing allergies. And that's the history of infant formula, but that's in there. So stages of lactation, if you needed to know, with the mammogenesis, so the breast develops through birth and puberty, completed. So the maturation of the breast is at pregnancy. We call lactogenesis 1 from mid-pregnancy to about 3 days postpartum. So really, the woman's already secreting or initiating the secretion of milk at around 16 weeks. And then it continues.
Sorry.
That's all right. I'll have to go through this rather quickly, but the most important thing, and you got some of that before, I think estrogen grows the ductile system. That's why we go through, did you have any breast development? So we know that the breasts are getting ready pretty much. There was estrogen, progesterone, everything's going well. I think the issue is, I'm sorry to do this to you. I just wanted to talk quickly about the prolactin receptor theory. So what that is about is the women breastfeeding, and we talk about demand feeding. So what I'm saying is that the more often the woman feeds or feeds according to the baby's needs, that's going to do that last breast development. So the woman doesn't just come, she has development, that's glandular tissue, then there's a little bit more occurring postpartum. The final imprint of glandular tissue to make the right amount of milk for the baby is the baby, and how often she allows the baby to feed according to the baby's needs. So the baby's actually creating receptor sites, and that sort of imprints her now to how much milk she's going to actually make for this baby in the end. So, and the other thing is not about, like overstimulating, it's about breast drainage. If you do not remove the milk correctly and optimally, then you're not going to actually make more milk, because there is a protein in the breast milk that will actually feed back to the brain to say you have too much milk, don't make any more. That's how I explain it to the mother. So the better the drainage of the breast, the more milk you make. according to the baby's needs without overdoing it or underdoing it. So this is what is expected during the pregnancy: antenatal education, skin to skin, the first breastfeed, and it's baby-led, that the mother and baby are together. So this is all about the 10 steps. It goes back to that. This is what I hand these women. We started redoing this for a little bit, so it gives them a general outline of what to expect the baby's going to do. Now, we're not trying to be really unkind and go after day 7, don't talk to us, but the evidence is that whatever I've got there on day 7, that's it until the baby's at least 3 months. So follow that guide. I usually say to them, this is how you know the baby's getting enough, this is how you know you're making enough, everything's going really well. And if it's not, express. So generally, it's about the baby's output, the baby, how the baby looks, and how she's feeling. If you're looking at the treatment of low supply with Galactogues, again, I've given the website for that, and we need to make sure that it's actually a low supply, or it's not just perceived. Again, with the use of Galactogues, if you do not remove the milk and you keep leaving the milk in there and you extend the time between breastfeeds, it won't work. It has to work in conjunction with milk removal. And you've got to be really careful with the use of domperidone. Again, making sure that they don't have any history of any cardiac arrhythmias, because it will, curtail their QT factors. So just anyone who wants to know anything about the supernumerary tissue, that's along the mammary lines basically, So the mammary lines go right from under the armpit all the way down to the groin. And so you can actually, if it hasn't recessed properly, then you're going to get accessory tissue. So you can have moles that the woman doesn't know is actually accessory tissue that will leak when she lactates, or she'll get these, auxiliary developments that are quite uncomfortable. Pretty much, we don't do much about it because it will involute. We don't overstimulate and it won't grow any bigger. It is uncomfortable. We just do conservative management. So let me just show you, those are the lines basically. So the complications quickly, nipple damage. That's always, and it always works out to be, I guess the general outline here is that we need to actually help them with basic positioning and attachment, remove the myths about what the baby's supposed to be doing. The baby never sucks on the woman's nipple, uses its tongue on the woman's breast to milk the breast. That's generally what it is, and that's our job, to do that and give them the information. The other thing with that picture is that woman also had breast surgery, and there was a relocation of nipple and areola. So she's had either augmentation or a reduction. Blocked ducts can be easily mistaken for mastitis, and it's not. You can usually see the tracking of the blocked duct, and it's focal. It's always about milk stasis. Again, it will be nipple damage, a milk stasis, not removing the milk enough, and the management's always going to be get the baby on properly, cold compress, and get the milk out, basically. Mastitis, again, inflammation. Again, if you go into our website and go through the policies, I have written everything down and what to do, including how we actually show these women best practice on that. That, as you can tell, probably is already developed. It's unresolved, and it's an abscess, multiple abscess. We still make the management conservative, aside from the fact that you already started on antibiotics. We do milk cultures prior to the antibiotics, because sometimes if you're not aware, if the antibiotics do not work, the woman has MRSA. Suppressing lactation, again, we've got a policy. So if you go into the website and see, can I just remind you, just one thing with suppression is that you do not have to not do anything, and don't scare the women about don't touch your breast. They can express for comfort. They're not draining the breast, so therefore they won't be making more milk. But they will certainly avoid blocking ducts and ending up with mastitis and abruptly weaning. And again, we have handouts and plans for these women who decide to do this. What else can I tell you quickly? The drug of choice is Dostonex, but again, we do conservative management, because unless the woman gets it within the first 24 hours and actually the first 12 hours, it doesn't actually work as such. And we do have the recommended dosage, so that's 1 milligram in the first 12 hours, or you can use it as a BD dose in the first 24 hours. So again, breast surgery, I don't think I have time for. We see a lot of breast surgery here. I guess my key point here for breast surgery is that they are referred, and I do the rest of the work for them for that. Augmentation is not, again, a blasé thing, because it can actually and will impact on breastfeeding and insufficient breast milk. Okay. So all this is on your slides. I'm sorry, there was just too much in there. Supports, we do have the breastfeeding support unit that we can refer to for the first 2 weeks for the women, and they can get one-on-one support. And all this information is in the baby's blue book, including the BSU. So thank you very much for your time, and I'm sorry I had to be so quick and I hadn't finished. Sorry.